Now let's move on to hematuria in pediatrics. So first we have to confirm that it is hematuria. Is it really blood in the urine or is it just red blood? So several things can mimic hematuria, whether it was gross or microscopic, dyes from Shamendar, anti-TB, rifampin, food dyes and candies or cakes, hemoglobin in the urine, equal in the dark brown, myoglobin in urine, menstruation in younger girls, and it could be factitious, which is very rare. So factitious and just يكذبون يحطون حاجة داخل العينة. To confirm hematuria, we use urine dipstick and urine microscopy لأنه قلنا ممكن يكون الurine microscopic. So how are we going to see it? With the microscope. So إذا كان centrifuged أو uncentrifuged. تعرفون السنترفيوج الجهاز هذاك عشان يفصل كريات الدم عن العينة السيروم نفسه. So if you have more than 5 RBCs centrifuged on a high power field centrifuged sample, نقول إنه microscopic hematuria. Or if we have more than 6, sometimes more than 10 based on other references, هذه الreferences, on an uncentrifuged sample, نقول إنه microscopic hematuria. So you're going to take a morning sample, no catheterization because it could cause trauma وينجرح, and we examine with no delay. I'm not sure why, but so classification according to the urine appearance. So this is what we do in the urinalysis. Microscopic hematuria, there is no urine discoloration. You can't see it. You have to detect it with microscopy or the dipstick. Whereas macroscopic hematuria, it is gross. The urine is visibly bloody, whether it was bright red or brown or tea-colored in myoglobinuria. مو myoglobinuria or يعني يشبه الميوغلوبينوريا أو يكون يعني very يعني a lot of blood. The color depends on the amount of blood and the source of bleeding. So 1 milliliter of blood per 1 liter of urine is sufficient to render urine as visibly bloody. زي البروتينوريا عندنا transient and persistent microscopic hematuria. Transient hematuria can be caused by normal stuff, عندنا fever, strenuous exercise. It is asymptomatic and usually resolves within a few days. No need for any further evaluation, so you just reassure the patient and their parents. Whereas persistent hematuria, I'm telling you, number 3. So hematuria is present in 3 out of 3 consecutive urine samples, and each sample is obtained at least 1 week apart. So معناته عشان نشخص إن واحد عنده persistent hematuria كم أسبوع نحتاج 3 أسابيع. كل واحد فيه عينة early morning sample ونشوف فيه hematuria. So present in 3 out of 3 consecutive urine specimens obtained at least 1 week apart. The etiology here is more than the etiology of proteinuria. So ممكن يكون عندنا glomerular, tubular interstitial, or it's not related to the kidneys, it's related to the lower urinary tract. It could be a vascular sort cause of bleeding, or we have coagulopathy. So glomerular causes are the most common. They vary from asymptomatic benign disorders to severe nephrotic syndrome and renal failure. Here, family history is very important, so you need to take a urinalysis. You need to ask about the urine of other family members and possibly obtain urine analysis later after diagnosis. So physical exam is also important. We always have to do blood pressure. يعني blood pressure هنا بيكون abnormal. We're always looking for hypertension. ليش؟ للمرميون عشان nephritis. Etiology of glomerular causes, which بنفصل فيهم, we have post-streptococcal glomerular nephritis, IgA nephropathy, and henoch-Schleien purpura, which is a type of vasculitis. Whereas for the second tubular interstitial causes, it could be acute tubular acute tubular necrosis، سواء انجرح التوبيولز نفسها سواء وماتت سواء بسبب shock صار في decreased perfusion سواء drugs that directly attack the kidney they are nephrotoxic أو عندنا tubular interstitial nephritis which could be drug induced or it is associated with autosomal dominant polycystic kidney. Lower urinary tract could be caused by obstruction or infection. So you have stones or hypercalciuria. الكالسيوم هو يطلع ممكن يجرح ال urinary tract نفسه. Okay, infections, foreign bodies causing trauma, neoplasms such as Wilms tumor, rhabdomyosarcoma, and trauma, kidney trauma, genitourinary tract laceration. إيش بعد عندنا vascular causes. They are rare and more commonly seen in neonatal population ينولدون فيها. ممكن يكون عندنا renal vein or artery thrombosis, almost invariably associated with I think هاي بناخذها بعدين في محاضرات النيونيتس. بس vascular typhoon they are rare more in neonates. And coagulopathy is a very rare cause of hematuria. بيكون البرزنتيشن حقه شو ما قاعد يروح البرزنتيشن حقه بيكون in other sites commonly عندنا hemophilia, thrombocytopenia and sickle cell hemoglobinopathy. هذا ملخص لهم. هاي glomerular causes, interstitial أو intrarenal causes, tubular interstitial cystic disease, autosomal dominant polycystic kidney disease, nephrocalcinosis, interstitial nephritis drug induced, acute tubular necrosis, الشوك كلهم يسمونها acute kidney injury يعطونا casts, nephrotoxins and tumors, الvascular سواء كانت trauma أو coagulopathies, lower urinary tract عندنا stones, infections, obstructions, foreign bodies, trauma. ممكن heavy exercise, loin pain, hematuria syndrome. طيب الحين نتكلم specific عن glomerular causes. نتكلم عن 3. أولهم هو ال post-infectious glomerular nephritis. Post-infectious from what? From البيتا hemolytic streptococcus. Group A beta hemolytic streptococcus. So this here is the most common cause of acute nephritis in children, specifically acute nephritis in children. Risk is increased in children between 5 to 12 and the male to female ratio is زي ما قلنا دايما بيكون 2 to 1. The pathogenesis هنا is a type 3 hypersensitivity عندنا immune complex diseases. These are big molecules of immune complexes عليها الانتيجين عليها الانتيبodies كلهم متجمعين and these are big so when they go through the kidneys to the kidney they damage the glomerulus, they damage the tubules. وهذا immune complexes, why are they formed? They are induced by the specific nephrogenic strains of group A beta hemolytic streptococcus. How do children get it? Usually after a skin or throat strep infection, they develop these cross-reacting antibodies to the glomerular membrane. يعني مو بس هذه immune complex disease بعد عندهم الauto antibodies للglomerular membrane. The resulting immune complex disease triggers complement activation and inflammation. So عندنا complement activation إيش بيصير؟ إذا كان persistent, we're going to use up our complement, leading to hypocomplementemia and decreased levels of C3 and CH50 in the lab investigation. So it is immune complex mediated disease. It could be asymptomatic with microscopic hematuria or full-blown acute nephritic syndrome, characterized by red to brown urine, proteinuria. It usually doesn't reach the nephrotic levels, but it could reach edema, hypertension, and elevation in serum creatinine. Elevated serum creatinine as a result of the acute kidney injury. So sudden immune complex is causing inflammation, a narrowed capillary lumen because of an inflammation, decreased GFR, accumulation of creatinine, acute kidney injury. So عادة بيكون عندنا history of infection with group A streptococcus, whether it was for the skin or throat infection. But there is a latent period before we see these signs. So a latent period between the infection and the post-streptococcal glomerular nephritis. So ايش هو؟ نرجع حقنا رقم 3. It's either 1 to 3 weeks following the streptococcus pharyngitis, or 3 to 6 weeks following a strep skin infection. ليش يطول أكثر السكن؟ لأنه هنا في عندنا natural barrier skin، على ما يدخل skin بعدين يدخل الجسم بعدين يطول شوية for 3 to 6 weeks. أما 1 to 3 weeks following the pharyngitis because it's literally inside your body. طيب قلنا it could develop into full-blown nephritic syndrome. Nephritic syndrome characterized قلنا by hematuria, proteinuria, hypertension. عندنا شيء اسمه azotemia. Azotemia is buildup of waste products such as BUN and creatinine. هو اللي قلنا يصير عندنا acute kidney injury بسببه. You may have a mixed nephritic and nephrotic syndrome. أهم شيء هنا نشوف إن في عندنا hypertension و hematuria عشان نقول إنه nephritic syndrome. Our laboratory findings here would be azotemia, so increased BUN and creatinine, and in a hematuria مع RBC casts or not. يعتمد على عندنا full-on nephritic syndrome with AKI ولا لا. فأهم شيء هنا hematuria. Varying degrees of proteinuria, whether it reaches the nephrotic range or not. Hypocomplementemia. Low C3 and CH50. بس أما C4 في الكومبلمنت normal يكون. أما في النفراك syndrome قلنا إن الكومبلمنت normal. وشيء مهم أهم حاجة هنا يكون عندنا positive streptoenzyme test على ال ASO titers. هذا to confirm إنه كان عنده أصلا strep infection. طيب هل يحتاج يكون active strep infection؟ No. قلنا إنه هي في latent period. طبعا ما بيكون active بيكون history. وال ASO titer حقنا it tells about a recent strep infection in the past 1 to 6 weeks, which is perfect for our presentation قلنا هنا. So 1 to 6 weeks. ممكن نسوي a throat or skin culture لو ما كان عندنا شيء definitive هنا. Our treatment, we treat the acute effects of renal dysfunction عشان وغالبا ما بيكون عندنا full-blown nephritic syndrome. For supportive, what do we treat? We're treating the hypertension, usually with دواء اسمه Lasix. Lasix here is a furosemide, which is a loop diuretic. We're also going to treat the acute kidney injury. So هذا medical treatment. بالأدوية ما نحتاج dialysis غالبا لأنه ما بيكون that severe. Patients with evidence of recurrent group A streptococcus infection should be given a course of antibiotics. So نعطيهم penicillin for 10 days. هذا عندهم إيش؟ recurrent infection. عشان أما إذا هم ما عندهم ما نعطيهم. وطبعا we will follow up for 3 goals. We want resolution of the acute renal injury, for the proteinuria, and for the hematuria. Our prognosis, majority, as in 95%, are self-limiting with complete recovery, and recurrence is extremely rare. But there's a small subset of patients who have late renal complications like hypertension, increasing proteinuria, and renal insufficiency, so عندهم النفريك syndrome. أما الغالب self-limiting. عشان كذا we only treat supportive. أضفت هذا هنا. إيه so clinical features of acute glomerular nephritis. إذا إحنا شاكين بشيئين بنسوي وعندنا evidence of streptococcal infection. بنشوف wait hold on هاي نشوف هذا أول. طيب بيكون عندنا complete recovery. When do we expect recovery? How do we monitor? Based on the lab results. قلنا عندنا proteinuria, hematuria وhypocomplementemia. The complement returned to normal within 4 to 8 weeks. هذا أسرع شيء. It resolves quickly because all we need to do is clear the strep antigens. When inflammation is stopped, we no longer use up our complement. Proteinuria, on the other hand, takes 6 months to resolve because we have structural damage to the foot processes with glomerular basement membrane permeability. فبياخذ 6 months. أما الهيماتيريا الميكروسكوبيك will resolve from 1 to 2 years. ياخذ وقت شوية نفس الشيء عشان كان عندنا structural damage. أوكي أيوة. طيب هنا قلنا إذا عندنا evidence of infection وعندنا acute glomerular nephritis. متى نقول هو acute streptococcal glomerular nephritis؟ نشوف إذا كان إذا serum complement levels return to normal by 6 to 8 weeks. قلنا 4 to 8 بس هنا by 6 to 8 نفس الشيء. نقول إنه acute post-streptococcal glomerular nephritis. أما إذا complement failed to return to normal ممكن يكون أي سبب ثاني زي SLE, cryoglobulinemia, vasculitis, bacterial endocarditis non-streptococcal post-infectious glomerulonephritis. فنقدر نقول إنه the quick resolution of hypocomplementemia is practically characteristic of post-streptococcal glomerulonephritis. My microphone died and I lost my recording. بس ساعتي بنعيد. So, IgA nephropathy. So IgA nephropathy is known as Berger nephropathy. It is the most common lesion found to cause primary glomerulonephritis. It is the most common cause of recurrent gross hematuria. And it is a common reason for persistent microhematuria. So it is very common. ما بيكون غريب لو قلنا إنه فينا يعني كثير من الناس هنا they live with IgA nephropathy and they don't even know. Gross hematuria, however, is usually associated with a upper respiratory tract infection, vaccination, or other illnesses. And unlike post-streptococcal and glomerulonephritis, the IgA nephropathy's hematuria may present a few days, like 2 to 3 days after an upper respiratory tract infection. Unlike اللي قلنا فوق, like it takes 1 to 3 weeks لو كان pharyngitis, or 3 to 6 weeks لو كان a skin infection. طيب, what is the pathophysiology? We have it's characterized pathologically by prominent globular deposits of IgA in the mesangium on immunofluorescence microscopy. So what is the mesangium? بطلع لكم الصورة بسرعة. Over here. So over here نشوف هنا هذا هو الكابيلاري حق الجلوميرولس, وهذا كابيلاري ثاني هنا capillaries. بينهم الانترستيشن اللي بينهم مو اللي يطلع في بول بين الكابيلاريز نفسها we have mesangial cells. So these IgA globules deposit over here. Now where were we? ما بقى لنا شيء. Yes. So on immunofluorescence microscopy, if you remember هذا من سنة رابعة هنا, عندنا لو كان deposits subepithelial أو subendothelial بيكون نشوفهم على الكابيلاريز وشكلها granular, نقط صغيرة 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 صغيرة. أما إذا كان linear فهو بشكل ما هو granular, شكل غير متقطع على glomerular basement membrane. أما هنا في IgA nephropathy عندنا ال IgA globules في الميزانجيال deposits فصايرة هنا قطع كبيرة. You don't see it you won't see it outlining the capillaries. بالعكس ما يعطيك هي specific shape. هذا هو على ال immunofluorescence microscopy. As we're used to, the male to female ratio is 2:1, and patients may present at any age. So مو شرط بس يجي الأطفال. In fact, the peak incidence is between the second and third decades of life. قلنا إنه كثير ناس probably يشوفون فيهم ما يعرفون because most patients live normal, healthy lives, as it does not lead to significant kidney damage. Yet, up to 50% in some studies have developed chronic renal failure and end-stage renal disease within their lifetime. And if they're children, they may display progressive renal dysfunction in adulthood, so these children need long-term, close follow-up. متى نقول عندنا less favorable outcome لو كان kidney damage symptomatic. So يعني عندنا significant, increasing, or persistent proteinuria, persistent hypertension, azotemia اللي هو increased BUN or creatinine, and less favorable outcome. طب التريتمنت is basically نفس ما قلنا هنا post infectious. It is supportive treatment. The primary treatment is appropriate blood pressure control and management of significant proteinuria using antihypertensive medications. So angiotensin ACE inhibitors and angiotensin II receptor antagonists are effective in reducing proteinuria and slowing the rate of disease progression when used individually or in combination. آخر شيء بنتطرق له الحين من أسباب الهيماتوريا Alport syndrome. Alport syndrome is also called hereditary nephritis. It is an inherited syndrome of progressive glomerular dysfunction that is associated with bilateral sensorineural hearing loss and ocular abnormalities. And this sensory hearing loss is not congenital. In fact, it runs parallel to the loss of renal function. فكل ما زاد عندنا damage to the kidney زاد عندنا hearing loss. Alport syndrome is a primary basement membrane disorder arising from mutations in genes encoding for several members of the type 4 collagen protein family. A genetically heterogeneous disease, Alport syndrome, results from mutations in genes encoding for alpha-3, alpha-4, alpha-5 chain of type 4 collagen, depending on which of these is mutated, يكون عندنا different modes of inheritance for this disorder. So Alport syndrome is mainly X-linked, but it can be autosomal recessive or autosomal dominant. Mainly X-linked, could be recessive, could be dominant. What are the clinical manifestations? Glomerular disease, ocular abnormalities, sensorineural hearing loss, and leiomyomatosis. So glomerular disease is asymptomatic, persistent microscopic hematuria. Microscopic mainly persistent. لكن ممكن تجينا recurrent episodes of gross hematuria. So هو دائما عندهم في البول الميكروسكوبيك hematuria لكن أحيانا تجيهم الجروس hematuria. It's also associated with proteinuria ولأن nephritis عندنا hypertension or progressive renal insufficiency. أما الocular abnormalities عندنا two characteristic abnormalities. عندنا شيء اسمه anterior lenticonus. So if you see over here, this is our lens. Our lens is protruding or bulging into the anterior compartment of the eye, forming a cone shape. Hence its name, lenticonus. ولأن anterior compartment قلنا anterior lenticonus. This abnormality causes myopia, astigmatism, and blurry vision. We also have a dot and fleck retinopathy. So we have macular flecks. Here's our macula and here's our fleck. And lastly, the sensory neural hearing loss, زي ما قلنا, it is bilateral. وآخر شيء leiomyomatosis اللي نعرف بعد إنه لها اسم fibroids in the uterus. لكن تقدر تكون في أماكن ثانية. So here are cutaneous leiomyomatosis. تكون زي ال So we have a collection of muscle tissue under the skin under the skin مع ال hair follicles causing هذا البولج, red bulges. So a family history of hematuria associated with renal failure and deafness is significant because Alport syndrome is hereditary. So a thorough family history is important. Now, what would be our workup? So in all cases, we always need to take blood pressure measurements, and all patients will need a urinalysis and microscopy. We'll need a urinalysis and microscopy. Urinalysis, checking for protein. O is signs of hematuria. والميكروسكوبيك microscopy عشان نشوف ال blood cells نفسها, عددها, شكلها, وإذا عندنا any stones, microscopic stones. We may need also blood works. So نسوي renal function test, نشوف البيان, الكرياتين, الفوسفات. نشوف complement specifically post-infectious glomerular nephritis مع ASO titer, anti-DNase, and a throat swab if we need a culture. We may consider ANA or ESR. ANA له systemic disease, ESR عشان نشوف inflammatory process اللي هو الآن موجود. IgA levels for IgA nephropathy. And we're going to check the urine calcium creatinine ratio in case of stones. We're going to do urine tests for other family members if they have hematuria. We're looking for Alport syndrome. We'll consider stone tests, looking specifically for for هذه substrates, I guess. Calcium oxalate citrates, uric acid, كلها من urinalysis حقنا. We may need an ultrasound or an abdominal x-ray in case نبغى نشوف في stones, renal vessel clots. So we're going to look at the size of the kidneys if we're suspecting any tumors or congenital deformities or any structural defects. And if we're suspecting a radio-opaque stone, بنسوي abdominal x-ray في حال ما قدرنا نشوفه بالultrasound. And of course, if you're still not sure, you can consider a renal biopsy, especially إذا في evidence of renal failure or systemic disease أو proteinuria مع الأسباب اللي قلناها فوق سابقا. Lastly, our take-home message: دائما نقيس الضغط وناخذ الوزن كل ما زاد فهو يدل إنه عندنا edema. Proteinuria, unlike hematuria, is considered pathologic until proven otherwise. قلنا الهيماتوريا ممكن يكون سبب ثاني, we need to make sure is it hematuria or just red urine. Nephrotic range proteinuria is always pathologic. قلنا أصلا proteinuria is pathologic. Nephrotic range proteinuria خلاص always معناته عندنا nephrotic syndrome. And if we have hematuria, we need to determine where exactly in the genitourinary system the blood is coming from. What 4 causes? ممكن يكون vascular, glomerular, tubular, or in the lower urinary tract. And lastly, if we have hematuria with proteinuria, our 2 star players in this lecture, or renal failure, this is really bad and we have to refer ASAP to pediatric nephrology. Now the questions here were a bit weird, so let's just go over them بسرعة. A child had a upper respiratory tract infection for 2 days and then hematuria for 3 days. Which of the following is the most likely diagnosis? 3, 2, 1. IgA nephropathy. لأن قلنا post-infectious عنده a latent period and it will present after 1 to 3 weeks. I just did the update. This is so weird. Okay, now we have a 3-year-old boy brought to the ER by his father due to abdominal pain. On examination, he's found to have a unilateral abdominal mass and hematuria. Which of these? It is Wilms tumor. هذا هو التيومر اللي ذكرناه في المحاضرة. Ewing carcinoma. This is for bones. Neuroblastoma. ما له علاقة. Maybe it has, actually ماني متأكدة. بس هذه ذكرناها في المحاضرة. Last question. Infant with microscopic hematuria. آخر شوية. Hematuria was 15 to 20. توقع RBCs per high power field. There was 0 to 2 WBCs, so we have no infection, no proteinuria. She has a history of pulmonary hypoplasia. She received caffeine, and I assume this is furosemide. Furosemide also is اسمه Lasix. Also, it is a loop diuretic. So this is a kind. هذا سؤال ناقص. So خلينا نمر عليه شوية. Would this be polycystic kidney disease? خليك شوية على جنب. Benign hematuria. You're not a diagnosis. Is this a UTI? No. قلنا WBCs لا. Is this kidney hypoplasia? خليك شوية على جنب. Is this a tumor? Okay, wait. So the most likely, which I see, is hypercalciuria, for one thing. No infection. وقلنا إنه she received caffeine furosemide. A loop diuretic causes excretion of potassium, of sodium, of calcium. So I assume إنه hypercalciuria يعني نزل الكالسيوم مع البول بسبب استخدام اللوب diuretic. يعني سؤال ناقص، بس ما أتوقع إن في كان structural defect. هذا كلهم structural defect. ما في طريقة إن نميز بينهم specifically in this case. So I'd say it is F.